A concussion is frequently described as an event where the head strikes something or something strikes the head. In the past, patients were thought to be malingering with their symptoms. However, with increasing understanding of brain injury, providers and athletic coaches have taken the condition more seriously. The American Academy of Neurology has developed a standardized assessment tool for concussions. A grade 1 concussion is where the patient might appear confused but no loss of consciousness. They may have difficulty maintaining a coherent conversation, however, but the symptoms should resolve within 15 minutes. A grade 2 concussion may have very similar symptoms, however, they last beyond the 15-minute time frame. Any loss of consciousness would constitute a grade 3 concussion, and the person needs to be evaluated immediately. The assessment tool makes suggestions for appropriate bench time before returning the athlete to play, depending on the concussion. With concussions, there is temporary disturbance in brain function, with no apparent structural damage to the brain, probably due to the fact of the brain being rattled inside the skull by a blow to the head, often also called the shaking of the brain. It could be a mild, diffuse brain injury, but if severe and with associated seizures or respiratory arrest, there may be permanent nerve damage. The patient may have confusion or loss of consciousness with retrograde amnesia, with the person asking, "What happened?" The effects resolve usually without obvious residual injury. Manifestations of cerebral concussion can include a possible brief loss of consciousness of less than 15 minutes, memory loss surrounding the injury, headache, confusion, and dizziness, as well as possible visual disturbances such as blurred diplopia. Increased pressure on the brainstem probably accounts for the slowing or temporary suspension of respiration or apnea and the reduced pulse rate that can accompany a concussion. Also, pallor and hypotension. Post-concussion syndrome is where after effects of the concussion, such as irritability, insomnia, dizziness, persistent headache, and intellectual impairment can last days, weeks, months, and rarely a year. On exam, usually there's no focal findings. Management is going to depend on the grade of concussion. It is also assessed individually. The patient may be hospitalized overnight for rest and observation or discharged from the hospital soon after the concussion. Typically, however, observation lasts at least 2 hours in the hospital, and then the patient is discharged for home observation. There is typically no radiological findings. Keep in mind that a person should be admitted to the hospital if there is focal neurological findings or extended period of unconsciousness. There needs to be other brain trauma ruled out if there is more than 2 minutes loss of consciousness. Cerebral contusion, on the other hand, is actual bruising of brain tissue. It is typically accompanied by small venous hemorrhages, and it results from the brain hitting the skull inside. It usually occurs with other serious injuries, such as blunt, penetrating trauma. It often also occurs with skull fractures and hematomas. Blunt trauma can include acceleration, deceleration, and as a result of the brain moving with the skull, there can be actual bruising itself during the acceleration or the deceleration movement. Also, bruising can occur directly below the point of impact, referring to coup, and then occurs in the opposite side, referring to the contra-coup, as the picture shows on your right. Brain swelling is at its peak about 12 to 24 hours post-injury. Because the brain is in a closed box, pressure increases as the brain swells, leading to increased intracranial pressure and decreased blood flow. We will learn more about the Monro-Kelly hypothesis, which will make it more clear. This is a scan of a patient who sustained severe head injury. You can see that there is extensive bruising on the right side of the brain, showing a large diffuse dark gray area. It represents swelling or edema. The white patches within represents bleeding in this area. Manifestations of cerebral contusion depend on the location of contusion, the size, and the amount of cerebral edema. Initially, there is a loss of consciousness. This can be gradually regained, or a full level of consciousness may never return, or there may be residual effects. So, altered level of consciousness may remain. Other manifestations include headache, personality changes. Person may be agitated, confused, but may remain alert. Hemiparesis in the alert patient if it's a frontal contusion. Keep in mind personality changes can occur more with a temporal contusion. Unequal pupils, vomiting, or other signs of increased cerebral pressure if edema. A patient that may be aphasic, especially in the frontotemporal region. But which signs and symptoms would you expect first? Remember changes of level of consciousness? Well, what about brainstem contusions? The patient will be immediately unresponsive or partially comatose because there has been significant brainstem disruption. So remember that there may be also respiratory, pupillary eye movement, and motor abnormalities seen. Altered level of consciousness may continue for at least several hours and days or weeks. Management of cerebral contusion is going to depend on the neurological state. We need to prevent swelling, avoiding low blood pressure. However, IV fluids may be needed to maintain a systolic blood pressure of more than 90. Hypertonic fluids can help reduce increased cerebral pressure, and osmotic diuretics can help decrease cerebral edema. We also need to prevent hypoxia. Remember that hypoxia is going to cause cerebral ischemia. Need to also prevent hyponatremia and hypercapnia. CO2 in the brain is a potent vasodilator, so that's going to lead to increased cerebral blood flow and further increases in intracranial pressure. Person needs to be closely monitored with their intracranial pressure. There needs to be serial CT scans to evaluate, and fluid restriction and salt supplementation if there is hyponatremia in order to decrease cerebral edema. I did not include this slide in your PowerPoint, so don't worry about it, but do understand that diffuse axonal injury is the most severe form of head injury. It is a primary injury of diffuse white matter that results in tearing or sharing of axons and small blood vessels. Sadly, the result is permanent death of the brain cell. Let's move on to epidural and subdural hematomas. Epidural hematomas are usually associated with skull fracture. The blood collects in the epidural space between the skull and the dura mater. Remember, the skull is a closed box, therefore intracranial pressure increases. There is buildup of blood that may compress delicate brain tissue. There is a skull fracture that is associated with epidural hematoma. Do you remember which one? Temporal. Remember what artery? The middle meningeal artery. Because it is arterial, it will develop rapidly. Time to intervention is vital. 2% of head injuries, about 15 and 20% of patients with epidural hematomas, die of the injury. Clinical manifestations include an increasing headache, ipsilateral fixed dilated pupils, seizures, motor weakness in the contralateral, and pathological positioning. Now know that epidural hematomas have a classical presentation. The patient has loss of consciousness immediately following the injury. Then they have a brief lucid interval followed by a rapid decline of level of consciousness to coma. The most accurate diagnostic study for epidural hematoma is a CT scan of the head. Also, a very thorough history. Management is going to include serial CT scans and intracranial pressure monitoring. As per contusions, we need to maintain ABCs, blood pressure, oxygenation, and how will we decrease cerebral edema? That's right, osmotic diuretics. The hematoma is neurosurgically evacuated through boreholes or a craniotomy. Almost always, management is surgical except for small lesions without neuro impairment, which could be monitored closely. Subdural hematomas are most often caused by head injury and usually result from tearing and bleeding of veins. As the name suggests, blood collects between the dura mater and the arachnoid layers of the meninges. So how quickly does the blood accumulate? More slowly than in epidural hematomas. The symptoms are similar to epidural, but slower in onset as the bleeding is typically of venous, not arterial origin. Subdural hematomas are more common than epidural hematomas, a classic finding in shaken baby syndrome, and also commonly seen in the elderly and alcoholics who have evidence of cerebral atrophy. Subdural hematomas are classified by the time elapsed from the injury to the symptoms. It's classified as acute if it occurs up to 2 days after the injury, subacute from 2 days up to 3 weeks, and chronic over 3 weeks to several months. Chronic is more typical of older adults and often associated with minor trauma. Clinical manifestations of subdural hematoma include headache, usually unilateral if conscious, drowsiness, confusion with chronic slowed thinking and lethargy, deterioration of consciousness, an ipsilateral dilated pupil within minutes or hours, weakness and paralysis in the contralateral side, and seizures, possibly from the high increased intracranial pressure and respiratory changes. Now, why would a subdural hematoma be often mistaken for stroke or dementia? If you're thinking because of its slow or delayed onset, you're right. Blood accumulates slowly, and symptoms may be very subtle at first. Diagnostic studies include CT scan, which is highly diagnostic for subdural hematoma. It can help determine if it's acute, subacute, or chronic. Again, chronic is often associated with minor trauma. Management. If it is small and without deterioration, observation and supportive care and time for it to be reabsorbed. If it's large with neurological compromise, immediate surgical evacuation with boreholes. Rebleeding may occur in the older adults and patients with alcoholism. Well, what about larger ones with hematomas? They may require open craniotomy for evacuation of a hematoma, which tends to solidify. Intracerebral hematomas are associated with contusions from closed head injuries.